other hall. So we will start the session and he will join us after one talk or so. So I welcome all of you to this session on intraocular lens implantation in pediatric eye. We start with the first lecture, intraocular lens power calculation in children. This will be by Dr. Vijay Kumar Sharma. Dr. Vijay Kumar Sharma is consultant at Army Hospital R&R, New Delhi. Each talk is 12 minutes. And after each talk, there may be some of the question after one or two talks.
Thank you, sir. Good morning, all of you. First IOL implantation was done, a series was published by Hiles et al. In 1977. Thereafter, with improvement in surgical techniques, equipments, instruments, microscopes, the IOL implantation in children is gaining a wider acceptance. One survey was done among the American Academy of Pediatric Ophthalmology and Strabismus Society from 1993 to 2001 that showed the increase of intraocular lens implantation in children less than 2 years of age from 12.9% in 93 to 81.9% in 2001. Although younger is the child, the more difficult is the problem of accurate intraocular lens power calculation because of the rapidly growing parameters of the eye. Now, there are various issues which are required, which should be handled while doing a pediatric IOL power calculation. The issues include the axial length, the keratometry, which intraocular lens calculation formula to be used, at what age the surgery should be done, and what the age has what effect on the growth of the eye if a surgery is done at that particular age. What should be the target refraction after the surgery to accommodate for the growing eye of the child, and how much of myopic shift occurs after surgery in pediatric patients. So I'll be taking them one by one. If we take into account the axial length is one of the most important factor for calculation of intraocular lens power. O'Brien and Clark, they calculated axial length in preterm infants born at around 33 weeks and found it to be around 15.38 millimeter. It increases at a very rapid rate after that at a rate of about 0.18 millimeter per week till 40 weeks. And it's about 16.6 to 17 millimeter at 40 weeks or at normal birth. After that, the axial length increases to about 18.2 millimeter by the age of 3 months. There is so rapid change in the axial length that is taking place at this point of time. And subsequently, the axial length growth decreases slightly, but it continues to grow till the age of about 15 years when it reaches the adult axial length value. Now, this changing axial length can lead to errors when we are calculating the intraocular lens power. In normal adult eye, per millimeter, about 2.5 to 3 diopter of error occurs in axial length calculation. But in smaller eyes, which are less than 20 millimeters, the error may be much higher. It is approximately 4 diopters per millimeters, and even smaller eyes, around 16 to 17, the errors may go from 4 to 14 diopters per millimeters, leading to remarkable change in the IOL power that is calculated. Now, axial length measurement, as it is less accurate for as compared to adults, the examination under anesthesia has to be done in infants and uncooperative children. Children have lack of fixation. They may have nystagmus. A-scan ultrasound biometry is done by two methods, either applanation or immersion. Both, there can be the errors. In applanation, the indentation of cornea can lead to significant error in the axial length, whereas during the immersion technique, since the probe may not be perpendicular to retina, that may lead to error. But one study compared the applanation and immersion methods for calculation of pediatric axial lengths, and they found in applanation about 0.28 millimeter less axial length is calculated compared to the immersion technique, leading to a remarkable size of error. Another important point is the ultrasound velocity of the biometer that we set in. Now, ultrasound waves move at around 1560 meter per second in aqueous and vitreous, but it moves, the movement is faster if there is a crystalline lens. So, in phakic patients, we should take, in phakic patients and axial length less than 20 millimeter, we should set the ultrasound velocity to 1560 meter per second. And if we are setting it to 1532 meter per second, then a corrected axial length factor of around 0.32 millimeter should be taken into account, and that should be added to the axial length. In aphakic patients, the ultrasound velocity should be 1532 meter per second. The next parameter which affect the intraocular lens power is the keratometry. Now at birth, the cornea of infant is very steep. It is about, the keratometry value is about 51.2 diopter at birth, which gradually flattens. And by the age of say around 6 months, the value comes out to be equal to adults, that is roughly approximately 43.5 millimeters. This is a small video depicting the calculation of keratometry and axial length. Now, handheld keratometer is being used for calculation of keratometry. At this point of time, the thing should be kept in mind that the speculum, the eye speculum that we are using, that should not be too tight. Otherwise, that may disturb the keratometry reading by stretching. As well as when we are calculating the axial length, the cornea should be kept dry, should not be kept dry. It tends to dry, so you can put the BSS solution over that to avoid errors while doing the calculation of with A-scan. The third factor after axial length and keratometry is the target refraction. Now, how much of target refraction we should plan? If we put a IOL power which is being calculated based on the axial length keratometry and aim for emmetropia, subsequently when the eye grow, the patient becomes very highly myopic. Whereas if we do a undercorrection for that age, the patient may be very high hypermetropic. And as if patient is highly hypermetropic, a young child, hypermetropia is highly amblyopia-genic. So patient can develop severe amblyopia if appropriate correction is not being done. So what should be the power that we should be putting to achieve the best results? There are many studies which have suggested, based on various parameters, that what power should be used. Based on axial length, Dahan et al. Had suggested that if axial length is around 21 millimeter, a power of 22 diopter should be put, and similarly with decreasing axial length, the increasing power, like if 17 millimeter axial length is there, the appropriate power that they suggested was around 28 diopters. Another study, guidelines published by NAD et al. They recommended a post-operative refractive goal of about plus 6 diopter if a child is 1 year old, and similarly plus 5 for 2 year old, and till 6 year old they did the undercorrection and kept the child hypermetropic, and they suggested that a plano lens, the emmetropic IOL power should be put in 7 years old and older children than that. There was a survey which was carried out by Wilson et al. In 2001 among the ophthalmologists who were members of ASCRS and APOS, and the various ophthalmologists, they recorded the responses and what are their practices. What they noted was that for infants less than 6 months of age, most of the ophthalmologists were aiming for moderate hypermetropia ranging from 3 to 7 diopters. Few were aiming for high hypermetropia and few were aiming for emmetropia. For infants at 12 months of age, most aimed for mild hypermetropia of 0 to 3 diopters. And at 2 years of age, there was a consensus among the APOS members to keep a child mildly hypermetropic or emmetropic. The infant aphakia treatment study also aimed for a hypermetropia of about plus 8 diopter in infants between 4 to 6 weeks, and from 7 weeks to 7 months they aimed for a hypermetropia of about plus 6 diopters. And at 1 month post-op, they found that only 41% of infants were within 1 diopter of target refraction. And they also suggested that greatest errors were for the infants whose axial length was less than 18 millimeters. So which IL part to be used? Although each individual case should be customized according to various factors which I'll enumerate in the end, but roughly by going through the various studies, the consensus is for children, say around 6 months, 30% under correction. From 6 months to 2 years, about 20% under correction. 2 to 4 years, about 10 to 20% under correction. And up to 6 years, one may go for 5 to 10% under correction. And after 6 years, one should go for emetropia. Although the Western literature is going more for emetropia at an earlier age. Like APOS member had suggested that more than 2-year-old infant, they should be aiming for emetropia rather than putting them hypermetropic error after the surgery. Now, after all these factors, the next thing comes is which IL calculation formula to be used. Now, as far as IL calculation formulas are concerned, there are regression formulas and theoretical formulas. Regression formulas are not accurate for smaller axial length. They are accurate for between 22 to 25 millimeter of axial length. Then generation 1 and generation 2 theoretical formulas. The difference between the two is in generation 2, the anterior chamber depth is also taken into account, which is again a variable parameter according to the axial length of the child. So, generation 2 theoretical formulas have been found to be more accurate in infants and children with axial length less than 20 millimeters. And various studies have been carried out, and consensus of these studies was that there is no suitable pediatric IL calculation formula at present, and all these formulas were less than satisfactory, and none had proven advantage over one another. So you can use a SRKT, you can use a Holiday 1 or 2, you can use a Hofer Q. So all of them are almost equivocal. There is not much of difference between all these formulas. Another thing which is available is pediatric IL calculator. Now, pediatric IL calculator has got various parameters which are fed into this, and based on this, you can design a post-operative refractive goal for a child. But the disadvantage with this is that this is a Windows 5 based platform. It has not been updated after that. It is based on Holiday 1 formula, and it has been found to be there is no difference in the prediction error between SRK2 and pediatric IL calculator has been found till date. And the last factor that I would like to discuss is the myopic shift. Now, after IOL is implanted, the eyeball is still growing, and various ophthalmologists have studied how much of myopic shift occurs. Wilson et al. Found a myopic shift of about 6.22 diopter in infants who were operated for cataract surgery less than 1 year old. Similarly, Plager et al., the infants who were operated between 2 to 3 years, they found a myopic shift over next 10 years to be about 4.6 diopters. And similarly, more is the age at which the surgery is done, less is the myopic shift subsequently. So finally, again,
Dr. Vijay, you have to sum up because
yes,
time is
right. So this is my sum up slide. So there are various factors which you have to keep in mind. An IL power for a patient has to be customized based on all these factors. And at present, there is no pediatric IL calculation formula which is available. I think hunt is on, and there might be someone in near future. Thank you very much.
Thank you, Dr. Vijay, for your nice presentation. If there is 1 or 2 questions for him, though we will take question after 3 presentations, but 1 or 2 questions we can take now. In the meantime, while second person is ready, Dr. Professor Tatyal will be ready, so you can ask any 1 or 2 questions.
Sir, normally the anesthetists, they do it, but yes, I think ketamine is better for short-term anesthesia because we have to give it for 5 to 10 minutes. It does cause. It does cause. If you're planning other things also along with this EOA, during the EOA, if you're planning to calculate intraocular pressure and other factors also, then you can have just sedation or some other type of anesthesia which doesn't interfere with this.
But ketamine is at present, we are not using ketamine at present. Maybe about 20 years back we were using ketamine. Professor Tatial will be speaking on IOL implantation techniques in pediatric cataract surgery.
Good morning, friends. Thank you, Dr. Jagatram. I think Dr. Rajesh is busy with election things. He'll be joining us. And we all know pediatric cataract has little different challenges than a routine phaco or any type of cataract surgery in adults. And Dr. Bijay had nicely, taken you to the various types of, calculation which is done in these cases. I have no financial disclosure for this particular presentation. Looking into a pediatric cataract surgery, the first most important thing is to have a clearance of visual axis that is on table by doing a good surgery and maintaining the visual axis for a long time. I think that is the most crucial phase of rehabilitating pediatric patients. And to that, the optical rehabilitation is done with the various methods, and one of them is intraocular lens implantation in these cases, because that is going to give a clear vision and you can avoid amblyopia in these patients. So you can have implantation, primary implantation at the time of surgery, that is primary, or you can have a secondary implantation. Both ways can be done in a pediatric patient. Depends on how the child is, the age of the child, the growth of the eyeball, everything will be important in these considerations. Looking into a primary implantation, you can have with PCC or without PCC, and with PCC with anterior vitrectomy or no anterior vitrectomies. So you have three options. You do an implantation without touching the posterior capsule. You have second option where you can do a PCC with implantation, and third option is PCC with anterior vitrectomy, and fourth will be capture of IOL. Let's see how we do it. So you have first option, a child less than 6 years, you can do IOL implantation within the bag, and you can do just PCC in that case. Anything between 5 to 8 years, you can do an anterior vitrectomy in these cases, plus minus. It depends on surgeon's acceptability and their results. But if child is young, then you have to do a PCC with anterior vitrectomy. If the child is infantile, people sometimes do optic capture also. But then in recent times, optic capture is getting out of practice because you can do a very good surgery in these cases. So always, in terms of IOL placement concern, in the bag placement is desirable in all cases. The incision has to be slightly enlarged. Like you do in adult cases, you can do a wound-assisted insertion, while in pediatric patient, it is always better to enlarge your wound and get your IOL implantation inside the anterior chamber, and always make sure your IOL placement is good. Because if you insert through the wound area, sometimes there's too much of pressure, your bag may get flattened, and you can damage the posterior capsule also. Therefore, high viscosity viscoelastic is desirable in these cases because the eye is elastic. You have to really form the eye nicely. So this is a small video showing this is a typical pediatric case, granular cataract. You do a good capsular access in these patients, which will be normally a capsular access forceps assisted, around 4 millimeter to begin with. Subsequently, you can aspirate these cases very nicely. After aspiration, clean the cortex from all around, 360 degrees. Capsule, this is a primary capsulotomy being done, which is slightly smaller than the anterior capsular axis. The size desirable is around 3 to 3.5 millimeter, so that you don't have too large or too small capsular axis. Subsequently, you can implant the IOL. If you see here, again the IOL will be inside the bag. I was telling that your cartridge should be inside, so the lens opens very nicely in the bag, because you have done a primary PCC. If the lens haptic goes into the rexus, then it will go into the vitreous cavity. So that should be managed very nicely. Remove the entire viscoelastic. If you have access to tricord, you can inject tricord at the end of surgery to see if any vitreous tag is there. So this is what I will say. In the bag implantation technique, you can do a PCC or anterior vitrectomy depending on the disease. Make sure a trailing haptic is dialed in the bag. Sometimes what happens in a pediatric patient, by the time you put the IOL, viscoelastic comes out, the pupil constricts. You can't see where the bag, your haptic has gone inside. The leading haptic will go in the bag, but trailing remains. So you have to make sure it goes inside. Otherwise, the lens will be half in the bag, half in the sulker. That will cause PCO in these cases, so which is not desirable. This is one of video of my colleague, Dr. Sudarshan Khokar, who does a lot of pediatric cataract surgery. Nicely done capsular rhexis of 4.5 millimeter. Doing a posterior capsular rhexis, which is 3.5 millimeter. And he'll do a vitrectomy in this patient. This was a child which was less than 2 years. Vitrectomy, the classically done is central core vitrectomy with a high cut rate. Cut eye mode should be there with a moderate parameters. Just go beyond the capsular rhexis margin also, at least 1 millimeter beyond that. So you have a nice anterior vitrectomy which goes right in the center, goes little beyond the posterior capsular rhexis. The scaffold has to be good enough so that you don't have a space for a cells to migrate on the central area. Otherwise, you have a reformation of membrane. The visual axis opacification becomes faster in these cases. The vitrectomy has to be done appropriately and slightly larger in the PCC. Make sure your haptic goes in between the two capsules and opens there. Otherwise, you can, as I said, you can have a posterior trailing haptic goes there, and make sure it opens very nicely. You can have a high viscosity viscoelastic so that maintains the bag, and rotate your haptic inside the capsule, which is the most important critical point here. Once both haptics are inside the bag, then you can do a re-aspiration. The aspiration is done with the vitrectomy only. This also makes sure that if you have any vitreous tag, that can also be released. This is his publication showing that his technique is good. Other one is, as I said, sometimes people put the IOL first, then do a PCC. That is also desirable in cases where you have a difficulty in controlling the PCC and you are worried about IOL getting in an improper position. And some people have devised a new technique of going pars plana and doing a vitrectomy through pars plana and taking away the posterior capsule after you have a proper implantation of lens in the bag. So both the techniques can be done, depends how it is suitable for you. The posterior capsular rhexis can be initiated by making a nick with MBR. Make sure your posterior capsule doesn't go far back. So when you're injecting the viscoelastic, it should be first injected onto the surface of the iris. So iris is pushed back, and then inject little bit of anterior capsule rather than too much of injecting the posterior capsule. Otherwise, the nick is difficult. So that is the most important critical point in doing a PCC in these cases. You can stain the capsule also sometimes. You can use the capsular rhexis forceps. The primary implantation in the sulcus is also desirable. Wherever you have a posterior capsule not supporting the IOL, you can take a 3-piece lens, put the lens in the sulcus, then optic capture this particular IOL. That also a good surgical options. So you have optic capture. You have 2 larger rhexis, then capture is not possible. If you have 2 smaller rhexis, that's also difficult. So you have to have adequate rhexis in these patients. The posterior capsular rhexis, you can have haptics in the capsular bag and optics in the capsular capture. So both can be done. And these are normally done with single piece lenses. We used to do in a PMMA lenses. But if you have a single piece foldable lens, sometimes this is difficult. But optic capture can still be done with a little carefulness. Then you have posterior capsulotomy, haptic in the capsular bag, and optic through the posterior capsulotomy with a vitrectomy assisted. That after you implant, you do a vitrectomy assisted PCC. Then you can haptic in the ciliary sulcus, which is a much desirable cases where you do both anterior and posterior rhexis get attached. So it's the double optic capture, which is a preferred mode of surgery nowadays to avoid peripheral cells coming to the central area. So this is a small video showing how we do anterior capsular rhexis. Subsequently, posterior capsular rhexis would be done after we complete the implantation, because this patient has pre-existing posterior capsular defect, congenital posterior polar cataract, where aspiration can be very nicely done. You can see large area of primary posterior capsular rupture which is there in this patient. Subsequently, you can implant the IOL in the bag. This is a single piece IOL implantation. After the implantation, then I do a vitrectomy assisted enlargement of the central opening and removing the vitreous, which is in a posterior polar, congenital posterior polar cataract. Sometimes you have a lot of anterior vitreous phase disturbances, a lot of granulation is there, and that has to be removed clearly so that you have a clear visual axis. Make sure the posterior enlargement doesn't go too far away, otherwise the lens placement may be difficult. So this is the one way of doing, safer sometimes. You put the IOL, you know that lens in the bag, it's difficult to drop the lens subsequently, then do a primary posterior capsulectomy with vitrectomy assisted. You can remove the vitreous with bimanual techniques and subsequently remove the anterior side also. The optic capture is quite simple with the desired size of rexes and desired size of IOLs. It can sometimes be difficult when you do a too larger rexes and vitreous is coming out. You have not done a proper vitrectomy. As I said in the beginning, you should stain before you implant the IOL, after implantation IOL also, to see the vitreous tags in your patients. Disadvantage of optic capture can be there. Sometimes it causes too much inflammation, and which is the important factor in infantile cataracts, while we don't do capture in an adult or a grown-up pediatric patients. Especially in a small eye with all those smaller bag, you can have inflammation happening in these patients. There are various literature supporting capture and posterior capsular rexes. The primary implantation with posterior capsular rexes without doing PCC is also desirable in cases who are more than 6 years old. There, these patients you can handle very nicely also. I normally keep around 8 years as a cutoff. Beyond 8 years, I don't do a primary capsular rexes. Less than 8 years, I do primary capsular rexes because if needed, capsulotomy can be nicely done in patients where these patients can be acceptable for doing procedure. The anterior capsular rexes should be nicely shaped. It should be at least 0.5 millimeters smaller than the desired areas. This is one case of small lens spherophakia patient where the entire lens is in the pupillary plane. Those granules are still intact. So these cases, once you aspirate the entire lens cortex with CTR placement, the lens bag gets stretched and goes behind. So you don't have to do entire sacrifice of lens in these cases of microspherophakia. If it picked up in an early phase, you can just stretch the bag with CTR and implant the lens. Sometimes primary capsular rexes also helps in these patients for making sure that lens is in the proper position. Once you do a surgery, it doesn't come in the pupillary plane and subsequent glaucoma is less in these patients. Incision closure is must in all pediatric patients. Both the main incision and side post incision should be sutured with rexes. Little bit of secondary implantation, the indication would be a patient who has good visual potential, and age is also consideration for a secondary implantation as soon as your parameters, as Dr. Vijay talked about, characterometric and excellent parameters are stable, refraction stable, that's the age for secondary implantation. And good age will be a school-going age. Before that, you have to manage with various optical devices to prevent amblyopia in these patients. So you have adequate sulcus, non-adequate sulcus. If you have adequate sulcus, you can place a lens in the sulcus, get an optic capture. You have no support, then you have to do other ways of fixing the lenses, that is a scleral fixation. So you can see here, if you have adequate support, you can put the lens, otherwise you have to suture the lens in the, with the suture, or you can do a transscleral fixation. So in this patient, you have a nice rim visible. Any pediatric patient you see in a post-op phase, pupil is not dilating, there's a synechiae. That's a good sign the patient has a capsular support. If there's no synechiae, everything looks clear, then you have no support. If you are having difficulty, pupil doesn't dilate, you can just do a UVM in these patients, see how good is a posterior capsular or a support in these patients, then plan surgery accordingly. And you can just put the lens as you saw in the primary position. Make sure the haptic open onto the iris surface. Then subsequently you can place in the sulcus. If you want to put this haptics into the sulcus, sometimes goes in the vitreous cavity. So that area should be carefully managed. But if you have a rexis which is smaller, you can open the rexis complex and get a capture done in this patient like you do in a primary surgeries. The adequate peripheral support should be seen in this patient. This is another patient. You can see a very nice peripheral support here. And you can release these synechias very gently because sometimes the synechia may be too broad and too thick. Try to separate that with a vigorous instrumentation. You can have a peripheral dialysis happening, bleeding happening in these patients, and that should be clearly managed. Make sure a patient doesn't have a glaucoma. All pediatric patients can have a glaucoma. That should be checked in these patients very nicely. So I would say optic capture in secondary implantation is much suitable, especially with the thin membrane or a support. Once you do optic capture, the lens doesn't move, it's stable. And unless the lens is not fixated, the lens movement can cause the iris shaping from behind, a lot of inflammation happening, a lot of complication in pediatric cases of IOL was because we used to put lens in the sulcus without capturing them. So once the concept of capturing has occurred, the chances of optic capture IOLs, position in a difficult scenarios, inflammation, glaucoma, hyphema has really gone down. So it's well understood that cases where you have a difficulties, always make sure you plan for secondary implantation. Where after do a large vitrectomy, pupil is small and the axial length is very small, less than 17 or a 16 millimeter, I normally don't implant IOL as a primary phase. Wait for some times, manage them appropriately. I think this Dr. Rajesh is going to cover scleral fixation. I'll just conclude by saying implantation in pediatric patient is little different than adult patients. The wound should be, it is more elastic and more difficult to manage. So it should be always sutured at the end of surgery. Place the IOL inside the entry chamber, start from entry chamber so that you can manage both haptics very nicely. Make sure both the haptics are in the bag. Never let your one haptic outside because that happens with a small pupil. Normally, infantile cataract, the pupil doesn't dilate that well. And anesthetists also little worried they don't allow you to use too much of adrenaline in these pediatric patients. So physically, you have to see by stretching your pupil and where exactly IOL is placed. And if needed, adequate vitrectomy should be done in all these cases so that you don't have a problems. And I remember Dr. Jagatram's publication where they have done a staining of vitreous before and after injection IOLs. In those cases also, they felt they have done enough vitrectomy. Next day, they had almost 20% of cases where vitreous stacks were there. So that's a clear indication that vitreous should be identified and complete vitrectomy should be done in these cases. Thank you.
Thank you, Professor Chittial. And now we move on to the next speaker, and that is none other than Professor Jagatram, who has immense experience in pediatric cataract surgery, and he'll be presenting on role of premium IOL in pediatric patients. Professor Jagatram, please.
एक ना ये लाइटें थोड़ी सी तो बंद कर देना। Thank you, Dr. Professor Rajesh Sinha, for giving me this opportunity to participate in this instruction course. I will be speaking on role of premium IOL in children. Implantation of IOL in pediatric cataract surgery is to achieve the highest rate of binocular vision. Pediatric cataract surgeons prefer to implant monofocal IOLs in children as it gives excellent distant visual acuity. The use of premium IOL such as toric IOL and multifocal IOL in children are gaining popularity. Monofocal IOL which are used in our setting are hydrophobic acrylic IOLs such as Acrisoft, IQ, SA6080, MA60AC, or it may be Technics sensor, or it may be Hoya 251, and at present we are using VVNex IOL, or it may be from the Orolab or Care Group. Premium IOL, toric IOL, or multifocal IOLs, or it may be even multifocal toric IOL. Issues of concern in children while using particularly multifocal IOL is almost 90% of the axial length growth take place by 3 years. Most of the younger children are uncooperative for biometry, keratometry and marking. So this is one of the issues, particularly while performing toric IOL implantation in children. Other issue is capsular bag phimosis or contraction. Primary posterior capsulotomy may also affect the position of the IOL in multifocal and toric IOL. Efficacy of toric IOL has been well established in several of the studies in adult, but we have the first study publishing the toric intraocular lens implantation with developmental cataract and pre-existing corneal astigmatism, which is published in Acta Ophthalmologica 2016. This is the study in children 8 years or more. What is required is online calculator, and for that we need pre-operative keratometry, biometry. It can be you can use IOL master, and we established what is the site of the incision and surgically induced astigmatism. These are the IOL of our choice, which we use at our setting. These are the Alcon, Acrisoft, Toric IOL or Technis Toric IOL. These are most commonly used. What is the critical factor for success is cooperation of the child, because the only marking you can do if child is cooperative, and then is the meticulous surgery and accurate placement of IOL. Such as this is one of the patients, and you can see this IOL is implanted at 86 degree, and post-operatively also it was found that it is almost the same, it is 100% same. But it may rotate, sometime it is not always so. I will like to show a small video. This is a 10-year-old child with zonular cataract with astigmatism. Marking has been done, and we initiated Rexis by needle cystitome, and then it is continued with the Utrata forceps. Size of the Rexis is kept about 5 millimeter. After hydrodissection, cortex is removed from the capsular bag. Capsular bag is filled with viscoelastic substance. Here is a IOL SA680-4. These are the marking on the toric IOL. IOL is placed in the capsular bag and is kept 15 to 20 degree less than the final destination. And after removing the viscoelastic from particularly behind the IOL, because rotation, this will prevent rotation, and this is how this final destination is reached. This is the exact alignment along the final destination. This is another child. This is the toric IOL. Already we have done Rexis, and this IOL is placed in the capsular bag. And this is the final destination. Viscoelastic has to be removed from behind and in front of the IOL. This is the another clip showing toric IOL in a 15-year-old male child, where there was a corneal scar contributing to astigmatism, almost 6 diopter. Marking is done before, and Callisto is used for guiding. At present we also use Varion, also using Aura for the verification of the IOL power as well as final destination, whether it is accurate or not. IOL is implanted in the capsular bag. And this is the final picture after IOL implantation. So what is important is centration. If for 1 degree it may be 3.3 degree loss of the lens power, whereas for 30 degree it may be total loss of cylindrical power. Excessive rotation can also induce astigmatism. Patient selection is important, such as regular corneal astigmatism, intact capsule, and in the bag placement of IOL. So, in conclusion regarding toric IOL implantation is possible in selective patient cooperative children undergoing cataract surgery with pre-existing corneal astigmatism. Now comes this multifocal IOL. Although there was study by Jacobi, which is published in Ophthalmology in 2001, but there were no long-term study or no study case series which is published. Accommodation loss after cataract surgery with need for reading glasses for near is a issue. So this problem is now being dealt with various multifocal IOL which are used in adult. But performance of these multifocal IOL in children, ours is probably the first study case series which is published. This study which we published was in Griffiths Archives Clinical and Experimental Ophthalmology in 2014. This is a study in children 5 years or more undergoing multifocal IOL implantation. So these are the various type of IOL designs. Particularly we have used refractive type of IOL in our study. And we used Alcon Restore IOL or Technis multifocal IOL. At present we are also using Symphony IOL. What are the key factors for the success of multifocal IOL? They are the patient selection, age of the child. Ideally, it is not suitable for very young children because even there will be changing IOL power of the child. Accurate biometry is important and IOL power calculation, and then comes meticulous surgical technique. Here is one of the child where Alcon Restore multifocal IOL is implanted in a 15-year-old child. So you have to perfectly do the rhexis. Here this is the rhexis and you have to remove the cortex. There should be no cortex in the bag. Because child is more than 8 years, so no primary posterior capsulotomy is required. And here we are using Alcon Restore IOL in the bag. It has to be implanted bilaterally. A removal of the viscoelastic substance. And this is the final picture. This is another eye of a child where we have used Symphony IOL in the capsular bag. So selection of the patient's child is important, and we have to do counseling of the parents. That once we implant IOL in multifocal IOL in one eye, we have to use the same for the other eye. These are some of the post-operative pictures. In conclusion, multifocal IOL solved the problem of near vision and spectacle dependency. But in our study, we could not could achieve that in almost 2/3 of the cases because child was in the growing age, and almost 70% of the children they could see for near and distance without glasses, and 30% of the children they still need glasses, because we kept that scope of enlargement of the globe or growth of the axial length, which I think probably once compensated, more number of children may achieve little more success. So multifocal IOL implantation improve the quality of vision as well as life and provide good range of vision at all the distances. Thank you very much.
Thank you, sir. It was indeed a treat to listen to your presentation. May I now request Professor Rajesh Sinha to deliver his talk. Thank you, sir.
Be presenting on the implantation of IOL in difficult scenario in pediatric age group. Now, pediatric cataract per se is a difficult scenario, but there can be situations which may be away from the normal situation in a pediatric eye, and I'll be just talking to you about a few of these scenarios which can pose difficulty while performing the surgery. Now, one of these scenarios is this. This is a case wherein there was a traumatic corneal perforation with a needle, actually, from the limbus, and then the patient, there was lens rupture as well. And then the repair, one suture was put, and then the lens aspiration was done. The capsule was damaged badly. So IOL was not implanted, and we waited for 3 months' time so that the capsule fibrosed, and then we could implant the IOL. Now, in this case, a multi-piece IOL is preferred. It is implanted in the sulcus. And if you can see, there is some amount of the opening here in the capsule. And since the margins are fibrosed, one can try to capture the edges of the optic of the IOL into this opening. And if it is captured well and it stays there, then it stays there always. It's rock solid and well centered, because there is always a risk of decentration of IOL in the post-operative period in a pediatric eye because of inflammation, synechia, etc. So it's always preferable to have a stable centered IOL, and this was possible in this case by doing an optic capture. Now, another scenario, a case of a traumatic cataract, wherein, as you can see, after lens aspiration is being done, you can see the opening of the posterior capsule. Now, this was detected long back, so the surgery was planned in such a way that the margins got fibrosed. So it was done nearly 4 months after the history of trauma, and the margins got fibrosed, so then you don't have a risk of extension of this margin, and you can even place an IOL, single piece IOL in the bag, and it remains solid. You can see the margins well fibrosed of the posterior capsule tear. Another option is that you can place a multi-piece IOL as well and do an optic capture or do a capture into the anterior capsule to place the IOL in the bag. But then in this case, if a single piece IOL is implanted in its position, that is always preferred, and this is the most physiological position of the IOL, so it has been placed. But that was only possible because we could wait for 4 months after trauma for this thing to fibrose. Another case of a traumatic cataract wherein there was dehiscence of the posterior capsule. So after doing the lens aspiration, the vitrectomy is being done at the edges of the capsule, and then a multi-piece IOL will be implanted here. Another scenario, a case of a post-traumatic limbal scar. Now, most of the times we don't prefer putting a toric IOL in a scar, but this was a limbal scar, and it was a long-standing scar, and the keratometry was stable for quite some time. So we planned to do a toric IOL. The 3, 6, and 9 o'clock position was marked, and then the exact axis was marked on the operating table. And this was, if I remember correctly, a 13-year-old boy. And so the exact axis was marked on the table, and then the lens aspiration was done. And here you can see a little bit of zonular dehiscence. So an endocapsular ring was placed. In a large amount of dialysis, we should not use a toric IOL, but in a dialysis, in a zonular dehiscence, which is post-traumatic, and a very small segment is gone, then in that case, you can stabilize the bag nicely with the endocapsular ring, and you can put a toric IOL. Now, another scenario, a case of a microspherophakia. This is another difficult scenario the beauty of microspherophakia is this, that the zonules are all intact in all the areas. So if you put an endocapsular ring, it stretches the capsule and you don't have to fix it. You don't need a Sionis fixation in these cases. Just a routine endocapsular ring can work. It stretches the capsule and then you can place the IOL in the bag. Now, sometimes if the subluxation is too much, like in 1 or 2 cases of microspherophakia, I've seen that the lens was absolutely plastered, it was absolutely in the anterior chamber. Sometimes you may have to do a complete lensectomy and do a scleral fixation of IOL. But in this case, it was a decent one, which you could see after stretching the bag, the IOL was well centered. Now, a severe subluxation of lens, in this case, you can't salvage it. It's almost more than 300 degrees of subluxation, zonal dehiscence. So in this case, intrascleral haptic fixation is being attempted. The sclera is marked at 1.5 and 3 millimeter positions on the sclera. And then 2 radial incisions are made between 1.5 and 3 millimeter positions. Lamellar dissection is done to create a flap and an adjacent groove in the same plane. So you just move your crescent blade even further from the second incision so as to get a groove as well as a flap so as to place the IOL haptic in the groove. And then an intralenticular aspiration is done. In this, you make 2 stabs into the subluxated lens. You put irrigation cannula of the bimanual irrigation aspiration into the lens. That helps not only to hydrate the lens matter but also to stabilize the capsule. You can pull the capsule, bring it in the center, and that ensures a complete aspiration of lens matter. This procedure, this technique was published in the Journal of Cataract and Refractive Surgery. So this helps in a complete removal of the cortical matter, and then you can remove the capsule with the help of a vitrector, so as to clear the visual axis completely. You can't leave that because subsequently the capsule will opacify. So you remove the capsule with a vitrector, the visual axis is cleared nicely, and then a multi-piece lens is used to fix in the posterior chamber. So an irrigation cannula has been placed and a multi-piece lens is being introduced. The tip of the haptic is held with a lens fixing forceps. It is exteriorized from the scleral stab incision. The second haptic is also being exteriorized. Now both the haptics are out, and now this haptic will be introduced into the scleral groove that was created adjacent to this flap. So both the haptics are being tucked into the groove, and then we put fibrin glue. After drying the area, we put fibrin glue. The flap is being positioned, and fibrin glue is also used to stick the conjunctiva. And in a pediatric age group, we should always put a suture, even if we have made this was a 2.8 to 3 millimeter incision, and this should always be sutured by a single interrupted Tenno suture. Now, this is a unique scenario wherein the IOL was implanted in a repaired corneal perforation with traumatic cataract, lens aspiration was done, repair of cornea was done, and IOL was implanted. Now, in that situation, it was put in the sulcus. Now, because of fibrosis and because of the zonal dehiscence here, the IOL is absolutely gone into one side. So, in this case, it has to be centered. So, the IOL is being brought in the center. And if you leave it like that, there's always a tendency for the lens to move again and get decentered. So it is always better to capture the IOL. So the IOL is being captured into this fibrotic opening in the capsule. And once you capture it, the IOL remains well centered always. Now, another unique scenario, a case of a megalocornea with corneal toricity, a 15-year-old boy. So, in a megalocornea, the size of this bag is quite big, and you cannot have a lens, absolutely well-centered, a toric IOL well-centered. Because the size of the bag is big, so there will be a tendency for the sunset syndrome. So in this case, if we have to implant a toric IOL, it has to be fixed somewhere. So after complete lens aspiration, the cortical matter aspirated, then a toric IOL is being implanted in the bag, and after putting both the haptics, the optic, and taking out the viscoelastic from behind and from above, the optic is being lifted up and it is being captured into the anterior capsular opening. And as you can see here, it has now been captured into the anterior capsular rhexis with the haptic in the bag and the optic just over the rhexis, and it is the axis being aligned to the mark made earlier, and then the remaining viscoelastic being taken out. So this enables the IOL to remain centered in its position, and the work of the toric IOL is fulfilled. The last scenario that I'll be presenting is a traumatic aphakia, case of repaired perforation with aphakia, with iris damage. There's hardly any iris left. So in this case, the only option left in order to provide good visual acuity and comfort to the patient, because the patient had a lot of photophobia, we had to implant an aniridia lens. Now, aniridia lens is a rigid lens with a 9mm optic size. So we have to make a large incision, and it is fixed in the posterior chamber by transscleral fixation by use of 9-O-proline suture. So as you can see here, this is a 9-O-proline suture needle that is being introduced to the scleral groove made at 1.5mm position from the limbus. Then it is taken out, and then multiple knots are tied around the eyelet of this haptic, and then this needle is again docked into a 26-gauge needle introduced to the scleral groove and taken out. The same thing is being done with the other haptic. Multiple knots are tied around the eyelets, and then the needle is exteriorized from the other groove. Now the incision has to be enlarged. So you have to be very careful here because the suture is there, so you have to bring the suture to one side and then enlarge on the other side. And then you place the IOL in its position, and then put one knot on both sides to titrate the centration of the IOL, because there is always a tendency to pull the IOL too much. So one knot is tied, and once you are absolutely sure that the lens is well centered, then you tie multiple knots, and this is the position of the IOL, an aniridia IOL wherein there was no iris and aphakia with a traumatic scar. The patient had a very good vision, 6/9 vision now, and she has been given glasses, and sometimes later we'll give contact lens also for 6/6 vision. Thank you very much for your kind attention.
Thank you, Dr. Rajesh Sinha, for excellent presentation. Your idea was very innovative, that putting toric IOL in boophthalmos.
In a megalocornea, sir.
Megalocornea.
Yeah, because the bag is too big in that.
Yeah, I know.
Yeah.
Usually what we do, we use 3-piece IOL.
Yeah.
We keep the haptics in the sulcus and put
Yeah.
optic into the bag,
Yeah.
making smaller rhexis.
Yeah.
But here you have done other way around.
Yeah.
That also worked, I mean to say.
Multi-piece toric lenses are not available in many
They are not
companies, so-
available for toric.
Yeah.
So that was a
Sir.
good idea.
Yes,
And for this last case which you showed, an iridia IOL,
Sir.
actually incision size has to be quite adequate.
Yes.
Because if you try to push, their haptics are very fragile,
Very
they may
fragile.
break up.
Absolutely.
And it has happened with me.
Absolutely.
So make adequate
Yeah.
incision so that optic goes well. Because it is
Absolutely,
close to, I think, 9mm or
9mm,
so.
sir.
9mm.
Yeah,
So it should not
yeah.
be small. If you
Yeah.
push, it will break
Yeah.
away and there will be problem, no?
Yes, sir.
So thank you so much for
Thank you,
nice
sir.
presentation.
Thank you, sir.
And now we will have the keynote address by Dr. Gerald Schulz. He will be speaking on surgery for congenital cataract in pediatric cataract. He is well known to every one of us and has done tremendous work in the field of pediatric cataract surgery. Presentation for us. I think you can ask questions because actually there is a constraint of time. We will try to finish. After that, you can surely ask question. Hopefully we will. Even now,
By the time he's putting up the laptop.
yeah, you can ask questions for us.
With time, does the astigmatism change, and how routinely we should use toric in children?
First part I can reply because I also presented toric IOL. Up to 6 years of age, there is a study in investigative ophthalmology and visual sciences that up to 6 years of age there is change of astigmatism. So preferably toric IOL should not be implanted before 6 years. There is another issue that there may be cooperation of the child may also not be good before that age, no? Though there may be some children which may be cooperative at 4 year, 5 year. So that is one, that 6 years or more we can implant IOL. Now we start with the keynote address, pediatric cataract. It is hereditary and acquired. So I think please.
Well, thank you, Dr. Sharma, and all of you for having me present this talk on what we're doing in the United States. And this work has been done privately and at Loma Linda, where Howard Gimbel had been our chief, and this was alluded to in one of the slides in one of his publications, and you'll see more of that. Yes, children can be difficult to examine. This child knows what's happening even before I walked in the room, and I feel it's so cute, but still the child has to be examined. I have a technique that I will start my examination outside the exam room, in the waiting room, while I'm playing with the child, and that child really does not know that he or she is getting an eye examination. And then finally, if I have to, I bring them in the room, but I actually bring a lot of my equipment outside, playing with the child, but the examination is being done. So let's go into the types of cataracts. We have the congenital or developmental. Congenital usually occurs before the age of 1, and developmental somewhat afterwards. It could be autosomal dominant, recessive, and also other causes. When it's genetic, it can have a high penetrance and variable expressivity. Now, of course, I'll be bringing a lot of genetics into this because for about 10 years, I chaired the genetics course here at AIOS. There's other causes, as I mentioned, and you can see up here what they are. Let's go into some of the syndromes that are associated with congenital cataracts. There's a whole slew of them. Most of them are, fortunately, fairly rare. But I do want to concentrate on Down syndrome. And the case that I will be presenting, indeed, has Down syndrome. Another one I want to highlight is galactosemia, because this is a deficiency of the galactokinase enzyme, and it is genetically inherited. And in a way, this became very personal, as I will bring out. Because with galactosemia, not only cataracts develop, with the increase of galactose, the body cannot break down the galactose, and therefore you can get brain damage, jaundice, kidney damage, etc., and unfortunately galactose is in even the mother's milk. I'm going to be talking a little bit about genetics, so from the genetics course, these are the bases, because I'll be using a term called missense. And what is missense? Missense is when you have one base substituted for another base, so you have a different amino acid being developed and therefore protein. And indeed, these are the problems of anomalies that are caused when you have genetic changes. Let's go into hereditary congenital cataracts. Here's a classification of various types of congenital cataracts and their locations. And let's take a look at them. We have the pulverulent meaning powder, and indeed it looks that way, powder. and it's generally from a gene on chromosome number 1 on the long arm. Q is usually the long arm, P is the short arm. Yes, I'm giving you some genetics from our course. And the coliform, it's like a settlement of in the seabed of calcium that develops and can have spickle shape, but you see this sort of in seashells, and this is a missense from cytosine to adenine at a nucleotide position, etc., but it is when you get a genetic change because of the change in amino acid and the protein. And the culiform congenital cataract is generally spickle-shaped. And again, this is from a different gene, on gene number 2. And the blue dot congenital cataract still from other areas. And here are the genes for the dominant cataracts. There's a lot of them. You have those that are within the lens protein itself and the lens membrane. These are the genes from proteins itself and the membrane. And these are for the recessive. But notice that many of these genes are also in the dominant. All right, I did say that this has personal meaning, so I'm going to go up close and personal because it involves the family of my nephew. Here's the proband, his wife, the one who introduced this family to me. Here's my nephew. Now, he has 4 children, all daughters. Child number 2, at 18 months, developed cataract in one eye, and then ultimately, later on, a cataract in the second eye, had surgery. The next child, a girl, had it at the age of 36 months and is developing now a cataract in the second eye. The youngest one did not develop it. The proband's brother, 2 children, no cataracts. Proband, another brother, 2 of them developed it. And look at this brother. Huge family. That's from Donald Trump. Huge! And 2 of them developed. But take a look over here. The proband's mother had... I ran out of power. We're not in here. Please help me with the power. Okay. Please make sure the connection is stable down there. At birth, the mother had it. And over here, the family 1 and 2, very poor tracking because they were Holocaust victims. They died from the Nazis, but from some photographs it was seen that the grandfather had a cataract. So this is a family history. It doesn't always occur to other people. It could occur within your own family. And we were looking at galactosemia for this family because it was fairly common. However, in galactosemia, you can get a teardrop type of cataract. Fortunately, this family did not have that. The children were not affected in any other way. Actually, they're extremely bright, so it's not that. Here's another patient, white cataract in one eye, developing it in the other eye, 12 years old. And here's another non-hereditary pediatric cataract, and here's one that looks teardrop in an 8-year-old patient of mine. So here's the challenges, and this was alluded to for lens power by Dr. Sharma. A lot of problems here. We want to avoid secondary membrane formation. We want to minimize the generation of Helschnick pearls and postoperative inflammation. Selection of lens power. And this was very well discussed by Dr. Sharma. The axial length, it increases rapidly up to the age of 2 and slower increase after 10. Corneal curvature, it's huge at first and then it decreases in the first year of life. This is simply a summary of what Dr. Sharma was talking about. And at the time of surgery, you've got to make that decision because you want to reduce amblyopia and avoid lifelong anisometropia. So this is a formula that Dr. Gimbel, my previous chief at Loma Linda, came up with and published. It was alluded to in the previous paper, up to 2 years of age, undercorrect by about 10 to 20%, 2 to 5 years, have a little residual hyperopia. After age 5, go for emetropia. And now the big thing is, as alluded to before, you want to reduce secondary membrane formation, and Dr. Tidwell discussed this very nicely and discussed a lot of the optic capture, because you physically want to block that secondary membrane formation, which really develops in children, less so in adults. And Dr. Vasalva also discussed this in an article that he wrote. So posterior capsulorhexis, sometimes with vitrectomy, but we do capture it in the posterior capsule. And acrylic lenses actually reduce the anterior fibrosis. Superior approach, this is my flow. A superior approach, again, trypan blue, wash it out, Helon 5, very thick viscoelastic. I use, measure it, a CCC, again, 5 millimeter diameter. Sometimes you have to use capsular scissors because it stretches, and again, phaco bimanual. Maybe you could use phaco, maybe you could just aspirate it. After that, clean out as many of the cells as possible. Then I put in the trypan blue prior to making the posterior continuous curvilinear capsulorhexis. I wash that out, put more Helon 5 in. I put a 3-piece lens in because that's able to stretch out and I have more confidence in a 3-piece than a single piece, because we are making an opening in the back, and I'm concerned about eventually plopping into the vitreous. Then I make behind the lens the posterior CCC. Why do I do it usually after I put it in? Because technically it can be tricky when you're putting the lens in, and sometimes your haptic could go under that posterior capsulorhexis. So I feel it's much safer and easier with less risk of complications to do that after you put the lens in. And again, an anterior vitrectomy. So when you're putting in your lens to capture it, first you push it in distally, capture it, and then proximally with the haptics at 90 degrees for it. Close the wound. In the United States, we have a glue called Resure. That can close it. That way you don't have to worry about sutures. Otherwise, use a tenovicral suture. I don't want to have to cut a suture afterwards because the child you'd have to put to sleep. Myocol, et cetera, et cetera. So here is how we do it. Many different ways. In this case, the haptics are in the bag, but notice that the optic is beneath both the anterior and posterior capsulorhexis. In this case, it's in the sulcus. This is sort of the preferred technique, especially if you're using a 3-piece lens. Other people will say, keep it in the bag, that's fine. And again, from Howie Gimbel's paper, this actually a very large posterior capsulorhexis, so we have it in the sulcus, and it's under the anterior capsule, but posterior capsule pretty much isn't even there. So let's take a look at this video that I made. This is a case with Down syndrome. You could use a ring to measure. Here I used forceps, and you'll see how easy it is to take out. This video might take a little time. My trypan blue, I do it under an air bubble. Theoretically, I avoid the trypan blue touching the endothelium. Putting in my Helon 5, because remember, the shell of the eye is thin and you can get a lot of collapse. Well, I don't have to describe this. You all know what I'm doing here. But again, I try to do it within the parameters of my markers. And if you have to increase it a little bit, so be it. I like using trypan blue for pretty much all my cases, because even though you can visualize the capsule, many times afterwards you really want to know where that edge of the capsule is, and it helps when you have trypan blue. And here I'm using the phaco, but you can see how easy it is to take the nucleus out. You could even do it with the bimanual irrigation aspiration technique without even the phaco, but just watch this thing suck out. And now the capsule. the cortex. I'm sorry. More air bubble, because now I'm going to stain the posterior capsule. The lens is not in the eye, but I'm staining it. Again, I want the best visualization. Yes, we'll put in that three-piece lens. In this case, it's in the bag. Now, I'll prepare, center the lens, make sure everything is okay. And then I'm preparing for the, under the lens, the posterior continuous curvilinear capsulorhexis. But I feel comfortable now because I have the lens in the eye. I know where the haptics are. I made it easy. Finish the capsulorhexis. And now I'm working on pressing that lens down into it, into the posterior capsulorhexis. So here the child is a few weeks after surgery. You can see how perfect it is. 9 weeks post-op and afterwards. And these are the people that helped me with my presentation.
Thank you.
And this is my youngest niece who was not affected. Thank you very much.
Thank you, Dr. Schulz. It was a wonderful presentation. Next we call upon Dr. Rohit Saxena to present on the amblyopia therapy, because pediatric cataract surgery as such many a times doesn't cause much problem, but post-op rehabilitation is something which is very, very essential. And so Dr. Rohit Saxena will be presenting about how to rehabilitate the patient, pediatric patient, after the IOL surgery, so that the patient does achieve the required outcome that has been intended by the surgeons.
Thank you, Dr. Rajesh, and thank you for giving me the opportunity. I've been advised that I have very little time, but it's very important to remember that very little time is not something that we have in children. And a great, superb cataract surgery, some of which you have seen just before me, are just the beginning of the war. And it's a long, drawn-out struggle. The aim is not to clear the visual axis, but to give good, clear vision. And remember, these are not small adult eyes. They're not miniature eyes that you're managing. So more than just doing a good, clean cataract surgery, it's important to rehabilitate them, besides looking for other neurological, developmental, and genetic disorders that these children have. So, of course, some of the post-op problems that we deal with in our amblyopia and refractive clinic is refractive surprises in the post-operative period, which you have to handle by add-on lenses, inflammation, uveitis, post-op opacification of the media, which are extremely important to be evaluated. So you do a great surgery, but you know that almost 80 to 100% of the children at some time in their life are going to have some degree of opacification, which you need to be very careful and follow up. Amblyopia, glaucoma, growth of the eye becomes differential the moment you put in a lens in one of the eyes, and myopic shifts, which you have to predict. So it's a big job to manage these children. So options for post-operative aphakic or refractive error correction. So spectacles, contact lenses, or intraocular lenses. Spectacles are satisfactory. Essentially, in fact, that's something which in India we're using extensively. But particularly if it's bilateral, it's a very heavy lens spectacle that they are dealing with. It's almost slipping down all the time. A small child just is not able to wear them. They're uncomfortable. Unilateral cataracts operated, you have a magnification factor which makes it very difficult for you to give good level of binocularity, even if there is good vision in one eye. And of course, spectacles are really unsuitable for monocular aphakia and really restrict visual rehabilitation. So contact lenses, which was actually in the West the standard of care before the IATS surgery, and although still, the study still, it remains very important, although unfortunately in India we have problems with that. The problems are poor hygiene, poor follow-up that we have, the cost, easily lost. Children here get to use it with dirty hands, so you have a risk of corneal involvement, and IOLs. Now, at least in our center, and I know many places have started shifting to putting in IOLs, especially unilateral cataracts, younger and younger. So beyond 1 year, many surgeons are now feeling more comfortable in putting in an IOL in the Indian setting, and it's really very practical in developing countries. It provides very good optical correction and closely simulates what is the visual system of the natural eye. But